Hi guys, welcome to chapter 10. This is alterations in immune function. The immune system is quite complex, and if you haven't reviewed it in a while, it's time to take a minute to review it. If you have some difficulty, one of the places where I would start is definitely chapter 9, talks a little bit about inflammation and immunity. Particularly a little bit on the understanding of our immune system, including like the barriers, like epithelial barriers and our phagocyte system and lymphatic system. You need to make sure you know a little bit about those. Going on to reviewing a little bit about our different leukocytes, our white blood cells, and what each one of them does. Particularly, there's a great chapter, figure 9.2 on page 160 of your book. That chart goes over the precursor cells, the stem cells that are going to make your different white blood cells. I think it's critical that you understand that because that's going to be really relevant in chapter 11. Continuing on with understanding a little bit about our different lymphocytes, which can and is our specific immunity and can be quite complex, including natural killer cells, T lymphocytes and B lymphocytes, remembering that the B lymphocytes are the ones that make plasma cells, or plasma cells, a type of B lymphocyte, where you're going to make antibodies. So make sure you review your antibodies, IgGs, IgMs, passive and active immunity, that type of thing. You also want to know maybe a little bit about complement and how you activate complement. You definitely want to go online and maybe find a video that helps you do that, because that's pretty important. And then a little bit on clotting factors and that cascade system on how to activate our clotting cascade. And then cytokines, there's a whole list of cytokines and chemokines on chapter 9, table 9.2 on page 171, but that is quite complex. Don't be bogged down too much by that. You definitely want to know about inflammation and how those kind of come up to be. And then I really need you to understand a little bit about adaptive and specific immunity, which starts from the major histocompatibility complex, MHC, and the genes that make MHC, called the human leukocyte antigens on chromosome 6, that are basically going to make your class 1, class 2, and class 3 MHCs. Right, those are going to be also pretty critical to understanding autoimmunity, which is part of our immune function alterations here in chapter 10. So just a little kind of stuff that you should definitely make sure you review before you kind of get into this chapter. So what is a little bit about our immune system, right? So immune system defends our body against invasion or infection by antigens. And just to review what that is, remember that an antigen is going to be located on the cell, like either our cells, our antigens, our markers that mark our own cells as self cells. Those HLA genes are the ones that code our cells. The MHC are those genes that I just mentioned, MHC1 and MHC2, the major histocompatibility. That's basically what identifies your body as your body. So that if you don't have the same genes with, say, a transplanted organ, then the body will interpret that transplanted organ as foreign. And then things that are foreign are going to try to be eliminated out of our body. So they're going to be attacked by our immune system. Right? So basically that's what it does, right? Our immune system patrols, right, and looks for these damaged and or foreign antigens in order for us to eliminate them, right? So one of the things that can happen in our immune system is that we have an overactive immune system, right? So an overfunctioning or hyperfunctioning of the immune system could definitely cause damage to tissues, right? Especially in the autoimmune world. The rheumatologists are the physicians that are going to basically take care of autoimmune disorders, which you will see are many autoimmune disorders, which are basically our body creating an antibody that, instead of attacking something foreign, is attacking our own tissue. And I know that seems like it should be that's an error, and in fact it is an error. It is obviously an erroneous thing, and because it is erroneous, and it's going to lead to disease. So just like you have a over response, just like you have hypersensitivities as well, you know, allergic responses, that type of thing, those are excessive immune responses. You can also have deficiencies of your immune response. And there's some of those deficiencies are genetic, and some of those deficiencies are acquired. Chapter 12 goes into the probably most important acquired immunodeficiency, which you know is HIV, right? Where we're basically going to attack our T cells, in particular T helper cells, which sort of breaks down the entire process of our immune system, as the T helper cell is the herald, the messenger basically that goes and identifies what needs to be done and which cells need to be activated. So when you attack those, then even though you may have the cells, the immune systems are never getting the message. So if they never get the message from the messenger, they're not going to function. That's basically a very simplified version of what's happening in HIV. All right, so those are two things. Again, we're going to talk about a lot of them in detail. So first of all, right, excessive immune responses. So autoimmunity. Again, autoimmunity and the immune system is when it's attacking your own cells, right? So we are making some type of B cell, which is, remember, a plasma cell that makes an antibody that is going to be attacking our own tissues. And you will see that the HLA antigen that is seen in some autoimmune disorders are listed on table 10.1. So for example, the rheumatoid arthritis is going to be a deficiency in the HLA antigen DR4, and therefore these genes, when the patient has a alteration in this gene, they are much more at risk of having this disorder. So if you look at rheumatoid arthritis, it's on page 187, it tells you that the frequency in patients who have this is 68%. In controls is 25, which means the patients who do not have rheumatoid arthritis do not have as likely this particular HLA antigen running in their family, the error in that antigen. And so the relative risk, which means the relative risk, if you remember from statistics, should be 1. Anything above 1 is higher risk. Anything below 1 is protective. So in this case, it is a 3.8. And 3.8 is much above 1, and so that is much higher risk for developing rheumatoid arthritis with an HLA antigen error in DR4. All right, so again, autoimmunity is an excessive immune response. Hypersensitivity is also, and there are 4 different types of hypersensitivities, and they are also going to have that excessive immune response. I'm going to get into them in just a second, but I do want you to understand that when the immune system works in overdrive, it damages and can damage tissues. Right? So autoimmunity, again, it's identifying its own cells as foreign and then starts to mount an immune response against that. So no single theory explains the origin of autoimmune disorders. So you basically have a breakdown of the understanding of self genes. So self-tolerance. So the breakdown of that understanding of what genes belong to our cells are going to be mediated by certain, again, antigens that we might have. It's polygenic, meaning that it's multiple genes, not just one, and it's multiple factors that might be involved in activating these types of genes. Remember, many times we can have a genetic predisposition, but that does not mean that we're going to develop the disease. We have genetic disorders that are absolutely, once they are there, they are going to cause a defect. there are some that need to be triggered by some environmental attack to our body. Right? So these are some of the possible theories. I'm not going to go into them in a lot of detail. It is not critical for you to really understand these. It is, however, super interesting, right? So the antigenic mimicry theory says that, right, the self-antigens are made of some of the same materials as other things. So some alterations in our self-tissue can lead to them being developed and then attacking our cells, or the sequestered antigens theory, that they are in there, right, during fetal development, but they are not going to be activated until later. We also have, thymus gland defects, which, remember the thymus gland, to just go back very quickly, one of the things that the thymus gland does is that it calls forth these, these lymphocytes, that are not yet specifically B cells or T cells, and they call them to the thymus. And basically they undergo a boot camp, like I call it, right, where only the soldiers that know how to not attack self antigens are going to be the ones that are allowed to leave the thymus and become mature T lymphocytes. The other ones will actually undergo something called clonal deletion, and they will be eliminated, and they are not allowed to survive, the ones that attack self. So one of the possible theories leads us to believe that the thymus gland is not working in the way that it's supposed to, right? T cell suppression can also be another function, because as I told you, the T cells are the ones that are going to basically attack your specific immunity, and also an alteration in T helper cell function, right? So again, some B cell theories where they lose their responsiveness to the suppressor T cell signals, and so they become overactivated. So B cells are overactivated. They start making many B cells, which can become plasma cells, and thus the plasma cells makes antibodies to our self antigens. Or the mast cell theory, where cytokines activate these mast cells into releasing and functioning and overfunctioning, right? So some genetic factors, again, cytokines can be associated with autoimmunity. So HLA genes and those genes that I mentioned, and MHC 1, 2, and 3, particularly MHC 1 and 2, which are actually mentioned in a really good chart on page 177 of your book, figure 926. It tells us a little bit about the ABC class 1 MHC genes and the class 2 DPDR and DQ MHC genes, and those are the ones that are basically going to be what we use with tissue typing. So if you needed an organ, your tissue types need to match the tissue types that somebody else is trying to somebody else's organ that they're trying to transplant into you. They have to match. These are the 6 things that have to match in order for your body not to reject that organ. And you know that even people who receive organs that are perfectly tissue typed with all 6 of them matching sometimes still reject organs. All right. So, and so there appears to be an increase, obviously, in autoimmune disorders based on differences in the MHC genes. Okay. And so gender is also a risk, and you'll see that females are at higher risk for autoimmune disorders. Again, everything comes with an environmental trigger. Just because you have this gene version, like for example DR4, which I mentioned in rheumatoid arthritis, you're not going to necessarily have the disorder. It just means that you're at higher risk for the disorder. I do want you to notice, however, if you go back to that chapter 10, table 10.1, the B27 HLA antigen is very high risk when it comes to ankylosing spondylitis, particularly in those people of Japanese descent. Incredibly so, right? So the relative risk is 207, which I remember relative risk needs to be around the number 1, which means it is no more or less likely to be at risk. Less than 1 means it's protective. More than 1 means that you are at a higher risk of developing that. All right. So, again, not just because you have a particular set, everybody has a particular set of HLA genes, right? Everybody has, their 6, HLA genes. But if you have a particular, viral attack, remember what viruses do. So again, these are all things you should already know, but I am kind of reviewing it a little bit. Viruses oftentimes are either DNA or RNA viruses. And what they're going to do is they're going to inject into your nucleus, right? The DNA, or if it's a retrovirus, RNA to then makes DNA, right? And that injects that DNA, incorporates that DNA into your DNA, and then it uses your machinery to replicate. Viruses do not have their own machinery to replicate. It needs to utilize your machinery, your DNA polymerase, your ribosomes, right, to make any proteins that it might be making. For the most part, it's really just replicating itself. So it's DNA or RNA that it's replicating. So you'll see that. Some environmental or occupational stress. Remember, stress, if you go back to chapter 2, does and can cause physical and physiological changes in our bodies. So anything can trigger these, especially in people who are genetically susceptible and have particular HLA genes. All right. So one of the things that you're gonna notice is also that individualized immunosuppressive therapy is going to be very much the future on how we are going to deal with things that we have not been able to really disorders that we haven't really been able to deal with. I want you to look at some commercials for medications that you might come across. And I want you to start to realize things like medications that end in the letters MAB, M-A-B. It's a monoclonal antibody, right? AB stands for antibody. If it has a U before the letters M-A-B, you'll see that it was actually tested in humans. And that actually is a particular antibody that is going to attack a particular antigen, right? So immunosuppressive therapy and basically individualized medicine is going to be probably one of the treatments of the future. Now, if you have a particular antibody that you're making in your cells, let's talk about how we can get rid of said antibody. All right, so I've mentioned to a few people before, and I believe I mentioned it here. My father had a particular autoimmune disorder called Churg-Strauss vasculitis. A vasculitis is a particular type of autoimmune disorder in which you have attacked to the small and middle-sized arteries. So the arteries become inflamed because of this attack by antibodies. One of the only ways to get rid of this particular antibody is to do something called plasmapheresis, which actually can filter. You're basically filtering your entire blood, and you're filtering your blood of this antibody. However, does that stop the antibody from attacking? The one that's presently in your blood, it would stop it. However, you do have a B cell somewhere that is producing this antibody. This antibody wasn't injected into your body, into your blood. It is being made by your red bone marrow. So the reality is that in order for you to stop an autoimmune disorder, you would have to do chemotherapy and kill your red bone marrow and then replace your red bone marrow, and then somewhere in there do a plasmapheresis to clear the blood that has the antibody. So basically, my father, when he was in the hospital, one of the things the rheumatologist told me was, this is what he has. This is the medication that we need to give him in order for him to stop making this antibody. And it's basically a chemotherapy drug. Okay. So, he was too weak at the time to do it. And unfortunately, my father did not survive, this particular attack, because some autoimmune disorders are very, very, they have a very strong attack, and this one was a particularly bad exacerbation, right? And even though he went into a small remission, it was exacerbated again, and unfortunately, that when upon the second exacerbation, he did not survive. All right, so so one genetic aspect. So which genetic aspect is associated with the development of autoimmune disease? So chronic or multiple viral infections, life-threatening anaphylaxis, B-cell epitopes, or MHC genes. I mean, what have we been talking about, right? So I'm going to let you figure that out if you haven't already been figuring it out. Okay. Another overproduction of your or excessive immune response is called hypersensitivity, right? This is a normal immune response, but that is inappropriately triggered, just such as allergies, right? Or excessive, and thus producing some undesirable effect on the body, right? Again, can damage your tissues, right? And it usually does not occur upon the first exposure. So basically, your specific antigen antibody reaction, right, or antigen lymphocyte interaction is going to be, again, excessive or inappropriately triggered. How many of us have had an allergic response to something? Like, I have an allergic response to shellfish. I do not have an anaphylactic shock type of hypersensitivity. However, I am always concerned that one day my reaction will be even more in excess of what I have now, and it will cause anaphylaxis. And so for many of us with allergies, we always have to think about, is the allergic attack gonna be worse the next time we're exposed to this? And that sort of leads us to shy away from things that we're allergic to. Probably self-protective. Okay? So type 1 hypersensitivity. So what is the etiology? So usually people with very strong type 1 hypersensitivities have even a hereditary or genetic link regarding an IgE response to our antigens, right? So in other words, you have an overproduction of IgEs. All right, so have very high IgE levels already going into that. So you'll see a lot of people with excess IgEs also have eosinophilia. So which ones are your eosinophils? All right. So eosinophils are a type of white blood cell, if you remember, and one of the things that they do is that they trigger the production of IgEs. Okay, so the pathogenesis, right? So it's also known as immediate hypersensitivity, where IgE is the mediating body, okay? And you are going to have a reaction very quickly after exposure, right? So after exposure to an allergen, you're going to have about 15 minutes to 30 minutes later a reaction in which the mast cells and basophils will release, right, histamine, and the histamine reaction is going to be quite strong, right? So the IgE binds to the Fc receptors on mast cells, right? They cross-link, right, when exposed to the antigen, and basically intracellular calcium results in this immediate massive local mast cell degranulation, which is basically, right, a release of these pro-inflammatory mediators, right? Histamine, right, is and heparin. Histamine, right, is a bronchoconstrictor, a vasodilator. Heparin is a anticoagulant, so it's going to decrease your clot formation, and it activates the kinin pathways, and other chemotaxic factors are also going to be activated, right? So you could see here the steps of a type 1 hypersensitivity. This picture is, let me see if I can find it in your book so I can tell you, because it's a little hard to read. Okay. Sorry, you know, I have, here we go. It's figure 10.1. It's on page 200. Okay, and so you can see exactly the steps that we just went through, right? So exposure to the antigen produces IgE antibodies on the right, that binds to the FC receptors on the mast cells. The mast cells are going to release and degranulate and release histamine and heparin, and you have your type 1 hypersensitivity reaction, right? And so increasing vascular permeability, right? Vasodilator, urticaria. So you might see hives, which what urticaria is. Very important word to know, because that's the word you're going to use in the hospital. You might see some smooth muscle constriction, especially bronchoconstriction, right? And then you will see pruritus, which is itchiness, right? Since the histamine receptor is activated, in mucus secretion. And so basically in the mild manifestation, you might have hives, allergic rhinitis, which is basically your leaky nose, right? Or eczema. In a more problematic, right, more severe kind, you might see throat constriction, localized edema, wheezing, tachycardia, and then obviously anaphylaxis being the most, right? Very small number of people are really highly allergic individuals who are going to be the ones that might develop anaphylaxis. Again, any point in time, it really can become worse than just having hives. Now, why would you use, for people with anaphylaxis, why are you going to administer epinephrine intramuscularly? I'm going to let you think about that. Okay. Right. So some of the treatments, right, antihistamines, I don't know about you, but being that I am an allergic individual with a little bit of allergic asthma, I am constantly taking Claritin. I live on Claritin, as probably many of you do, and that's an antihistamine. Sometimes we might even need Benadryl. Okay. Beta adrenergics are also going to be used. I also have a beta agonist, which is going to release or reduce my bronchoconstriction. It's called Ventolin or albuterol. All right, a corticosteroid. I don't take one currently, but I have taken prednisone in the past to decrease the inflammatory response. It's very common for people with autoimmune disorders to be prescribed prednisone. That is going to decrease their inflammatory response and decrease their immune function, because that's really the only thing you can do. In the meanwhile, prednisone has lots of really bad side effects, and so you're going to make sure that you know those. And then anticholinergics, another way to block that type 1 hypersensitivity, to block the parasympathetic system. Right, so in longer term, right, IgE therapy, right, also inhibits binding of the IgE to the mast cells. And then epinephrine, right, given subcutaneous or IV during acute allergic reactions. So why do highly allergenic people carry an EpiPen, right? Because epinephrine, right, is a bronchodilator. It's works exactly the opposite of histamine. So it is basically going to cause, it might cause a vasoconstriction, but it's definitely going to cause a bronchodilation. And if it's given IV, it's going to obviously be propelled through the heart, and then the heart rate can increase significantly. All right, so prevention, right? So in infancy and pregnancy, right, several methods have been developed to sort of decrease the chances of type 1 hypersensitive reactions in high-risk patients. And most of the time what you're going to see is desensitization, which is a series of injections that are going to sort of mediate the response of your body. So for example, a child that might be known to have a really severe peanut allergy, they're going to be slowly given small dose, starting with very small doses of peanut, right? Basically peanut antigens, right? Because you have to go back into the chapter and notice that peanuts and penicillin aren't fully antigenic. They have epitopes that are partially antigenic. It's all in chapter 9, so you want to make sure that you understand that a little bit, and that our body kind of completes the puzzle piece and makes these things become something that we can have allergic response to, right? So pharmacologic desensitization to these factors are going to be the only way that those people with severe allergies can basically minimize their allergic responses. All right, so a type 2 hypersensitivity reaction, right? You might also hear it called tissue-specific or cytotoxic or cytolytic hypersensitivity, right? Is characterized by the antibodies, right, that attack antigens on the surface of specific cells or tissues, right? And then they cause lysis of the cell, right? So what you'll see is antigen antibody complexes being made, right? And then so you're gonna have basically an activated antigen antibody complex, which then can lead to cell lysis and activated complement. All right, so you can see the steps here, which is this picture. Again, is found on page 202. It's figure 10.2. So just like the mismatch, the blood transfusion mismatch reaction, that's what a type 2 hypersensitivity reaction is, right? So we have antibodies that float in our plasma. Remember, that's part of our blood, but it is not in our red blood cell. Our red blood cell has antigens, and the antibodies can't match the antigens on our cells, right? So I'm type B blood, and so because I'm type B blood, I'm gonna have type A antibodies, right? So if I were given type A blood by mistake, right, some type of, right, blood mismatch reaction, what's gonna happen is my antibodies to the A antigen are going to bind with the A antigen on the surface of the red blood cells that I was given, and they're going to clump, and this clumping is going to cause basically a type of clotting that isn't something that you are going to be able to undo. So this type of clotting is basically called coagulation, and this coagulation is going to basically stay there until you filter the blood out of this these clumps. And so this type of reaction is quite serious. Not very common, as we are very, very careful in this country to make sure that we give you O negative blood, so that the O negative blood has very little, if any, antigens. There are some very minor types of blood groups, antigens that are found on red blood cells that are very uncommon, that might be present, that are not necessarily tested for, unless there are people who know that they're positive for that particular factor. They need to wear a medical alert bracelet, because since we don't test for it in the general population, a person has this, they may have a blood mismatch. So for people who are, for example, if you look at the major blood groups, on page 203, table 10.4, there's one called the Duffy antigen, and if they have the Duffy group or Duffy blood, the Duffy group is a very rare, but obviously enough to make the chart, right? Blood type that if you are positive for the Duffy antigen, you need to wear a medical alert bracelet. And if you are scheduled for surgery, you are usually going to be asked to donate your own blood in case the blood product is necessary or if it is necessary, you will be donating blood so that they can administer your own blood. So they'll collect your blood maybe, 50 or 60 days before surgery, so that you already have a pint of your own blood already available. Right, so it's a transfusion reaction, right? So the recipient's antibodies attack the donor's red blood cells. That's the one. That transfusion reaction is the type 2 hypersensitivity. So you might also see a hemolytic disease of the newborn. So let's talk about how this happens. I want you to understand that the mother who is negative, whether she is A negative, B negative, AB negative, or O negative, right? An RH negative mother of any letter, so it doesn't matter which letter, but if she is RH negative, which means carries that negative sign, that means that she does not have the RH antibody on the red blood cell. So since she does not have the RH antibody, she is of a minor number of people in this country that do not have that. Majority of people, if you look again on page table 10.4, 85% of people are RH positive and only 15% are RH negative. That is very different depending on the country of origin. I know that many Asian countries are 99% people are RH positive and only 1% are RH negative. So very, very different depending on the country of origin, of ancestral origin. Right? So RH negative, the mother, if the baby, right, which usually will be the father, will probably be RH positive, since it's 85% of people are RH positive. They are going to have a child that is probably RH positive, since the one parent carries the positive gene and the other parent does not, and this is a dominant gene. You're going to have, most children will be, a very great majority, will be positive. Right? So mother is negative and baby is positive. During pregnancy, mama's blood and baby's blood do not mix. However, after, when they are being born, this is a big bloody mess, and baby's blood is going to be exposed to mama's blood. And mama's blood, because this is a foreign antigen, she does not have the RH factor, it is foreign, she will develop an antibody to that foreign antigen. And first baby is fine. Second baby, third baby, fourth baby, antibodies are much smaller than red blood cells, right? So red blood cells don't cross the placental membranes, but the antibodies do. And so because they do, they are going to then cross and they can clump or coagulate, like I mentioned, agglutinate. That's the word that you use. The agglutination reaction is going to occur in the baby. And when agglutination occurs, which is kind of that coagulation, is very, very hard to separate. That basically going to obstruct flow of red blood cells with oxygen to the brain, to the heart, to the lungs, and the baby will die. This can happen very early on in pregnancy, probably within, 20 to 25 weeks of pregnancy. So either the baby is delivered prematurely in an effort to try to save the baby's life, or the baby will probably die. All right. So what they do for women who are Rh negative is they give you this RhoGAM. So RhoGAM is basically an antibody to the Rh antibody. So if you make the antibody, this antibody is already present in the blood, right? So we give it kind of like an anti-venom, right? We put it in the blood, and it prevents you from making more of that, or prevents you from making that antibody after exposure to the D antigen, right? So the mother can have other babies without a problem. All right, type 2 hypersensitivity is also seen in myasthenia gravis, where you see the basically an antibody attacking the acetylcholine receptor. Okay, so at the neuromuscular junction. So myasthenia gravis is going to be quite serious because, as you can appreciate, when you block the acetylcholine receptor at the neuromuscular junction, you're not going to get muscle contraction because there's going to be no depolarization at the neuromuscular junction. All right, and then some other examples are Graves' disease and lymphocytic thyroiditis, right? So the neutrophils, right, are basically blocking, right? They bind to target cells, blocking the receptor from functioning normally, causing injury or malfunction of the tissue. So you can see here, myasthenia gravis, right? And this is your neuron and synaptic knob. These are the little vesicles that deliver acetylcholine. And then the acetylcholine is going to bind. So instead of being able to bind to its receptor, all of these antibodies are bound into the receptor. So basically they have the same shape in there at that Y shape. And I want you to review what that Y shape is, because that Y shape is actually the shape of antibodies. They have a light chain and a heavy chain, and that at the very tip of that Y is where it's going to be the antigenic area. All right. Now, a graft rejection, a hyperacute graft rejection, is another type of type 2 hypersensitivity, right? And you'll see that, right? Tissue and blood typing usually prevents these types of graft rejections anymore, but before, you had more graft reactions. So in a type 3 hypersensitivity reaction is also called immune complex reaction, right? Is when the immune and phagocytic systems fail to effectively remove antigen antibody complexes. So basically what happened in type 2, right? You're going to have an antigen antibody complex. However, this reaction is not going to be able to be eliminated from the body. So it's not necessarily tissue specific, right? So what does an antigen antibody complex do as it's floating around? What it'll do is that it'll activate complement, right? And again, remember I told you, go back to chapter 9, or maybe find a video online that helps you understand a little bit about what complement is, right? And then by causing you to activate complement, you're basically going to have a lot of cells dying, because that's basically what complement does, is that it's going to basically degranulate and kill cells. Right, so lupus is an example of a type 3 hypersensitivity reaction, as are serum sickness. You might see some drug-induced vasculitis as well. All right, so what might be the etiology of a type 3 hypersensitivity, right? So a history of infection or low-grade fever by a microbial or viral agent that might cause a type 3 hypersensitivity. An extrinsic environmental antigen from mold, plants, or something inhaled into the lungs, or an autoimmune process in which autoantibodies attack self-antigens. So any one of those can be, remember, etiology is the cause of this particular hypersensitivity, right? So it activates complement and other pro-inflammatory mediators because of this antigen-antibody complex. The antigen-antibody complex deposition itself does not cause the injury. So the mechanism of the injury is the inflammatory reaction to the antigen-antibody complex. So complement is basically the mediator that which accomplishes this, right? And then, so phagocytic cells are attracted to the tissue, causing tissue damage, right? So the antigens, right? Antigen-antibody complexes form. They're deposited into the tissues. If the immune complexes are not removed, right, it causes an inflammatory response leading to that tissue injury. They activate the classic complement cascade, right, which again is something you want to review, and basically is going to attack and destroy cells. So the phagocytic cells, right, are going to die and causing obviously damage to that tissue, scarring of that tissue, and then tissue that is no longer functional in the way that it was before. So you can see there the antigen-antibody complex is now kind of deposited into the tissue, right? You're going to activate, right, activation of complement, and then it releases the enzymes and free radicals and causes tissue destruction. That one is on, this picture is on page 205 in case you're following, right? So again, it could be that it is a short, right? But it's usually for long periods of time, and it's going to, after a long period of time, increase the immune response. So larger complexes can be phagocytosed very easily, right? Or marked by complement, transported to the liver where they're phagocytosed, but they can become stuck in the kidney as the kidney is trying to filter out these things out of the body, right? And then they get stuck in the glomerular basement membrane, right? Immediate ones are going to be deposited into the tissue. So the very large complexes are usually not going to be the ones that cause it. The really small ones probably will, not cause it, but the intermediate sized ones will probably cause it. So one of the things that it might cause is glomerular nephritis, right? So typically about 10 days, 2 weeks after a streptococcal or staphylococcal infection, you might see deposition of this immune complex into the glomerular capillary wall. And again, I mentioned lupus, systemic lupus erythematosus, right? Much more common in women than in men. And basically is when we develop antibodies against nuclear antigens, such as DNA, DNH, and RNA. Very difficult to diagnose because of the variety of signs and symptoms, and usually they'll have a list of signs and symptoms, and if you fit that list, like say 5 out of 8 of those on the list, then you would be diagnosed with SLE or lupus. And then type 4 hypersensitivity is the type of hypersensitivity that's like a delayed hypersensitivity. So you have no primary antibody involvement, and it's basically lymphocyte involved. So the other ones were all like basically antibody involved, and then these delayed hypersensitivities are going to be T cell or macrophages, right? So you could see sensitized T cells very commonly, right, initiating inflammation and cell destruction against foreign cells. All right, so you could see that on page 207, okay, where the epidermis, for example, has a haptene, right, which is basically going to form a complete antigen with that epitope that I mentioned. You are going to then have an antigen processing cell, or like a macrophage, and then that migration to the lymph node where it is presented to T cells. APCs are also called antigen presenting cells. This is a antigen processing cells. It's a slightly different name, but you might more commonly I have seen antigen presenting cells, and then they're basically going to activate right at the lymph node, activate T cells, release of cytokines, activating macrophages, and basically migrating into the dermis, releasing inflammatory mediators and causing cell destruction. Type 4 hypersensitivity reaction. Basically, poison ivy is probably the most common one of our type of 4 hypersensitivities of contact dermatitis, basically contact hypersensitivity. Right, so it's the most rapid type. You'll see skin swelling, and you might see some graft reactions and rejection as well. Right, contact hypersensitivity, the most familiar type, peaks about 48 to 72 hours. The haptene is very small and incomplete antigen. It becomes complete when it attaches to that carrier that I mentioned. The tuberculin type of hypersensitivity, if you have been previously infected by tuberculosis, or if you've received some types of vaccines for tuberculosis, you might also come up positive on this tuberculin test, right? That basically causes that little circle like you usually put on your arm, right? And you're basically looking for the size of that circle. And so the bigger the size, the more of a reaction you have, indicating that you have a antigen present in the body. But again, you can receive that from vaccines. Okay. Also another one, granulomatous, granulomatous, hypersensitivity. Right. So basically, a chronic type 4 hypersensitivity reaction that eventually can cause tissue destruction, because the antigen is basically not stored within the macrophage. So forms granulomas. You might see scar tissue, especially in caseous and cheesy necrosis of the lung. All right. So which of the following orders displays these characteristics, right? Failure to remove antigen antibody complexes is not tissue specific, includes antibodies, occurs over several hours or days, and also called an immune complex reaction. You probably know what this is. All right. Now, deficiencies of your immune system, right? So kind of the opposite, all the way on the other spectrum. Again, some of these are genetic, and some of them are not, and some of them are acquired. Okay, so basically, two types, right? Either congenital, or sometimes, remember, congenital means you're born with it. Primary, and some of them are secondary, where they're non-immune system disorders. And so some sort of treatment might affect immune function, right? So deficient immune responses can affect all of your complement proteins, your lymphocytes, your antibodies, and so on. Right? So again, it could be genetic. It could be that it is congenital and you're born with that. So some of the signs and symptoms, right, might be the first clinical indicators that something might be wrong. It is rare. Primary immunodeficiencies, often sex linked, right? Many babies with primary immunodeficiencies will get sick very, very often, right? So recurrent, unusual, or unmanageable infections. So babies that get sick very often, maybe even get, streptococcal or staphylococcal skin infections, which are not very common. Continuously getting ear infections, those things, they might indicate primary immunodeficiencies are quite serious. Okay, this is not like, well, a baby who gets lots of infections is always going to have a primary immunodeficiency. These are quite rare, right? It's pretty severe. Immunodeficiencies, if the more severe they are, the more clinically significant they're going to be. So, for example, the most severe kind is called SCID, severe combined immunodeficiency. Basically, it is inherited and they have no B or T cells, right? Right. It's basically an complete immune system dysfunction, right? Wiskott-Aldrich is another type of immunodeficiency. And Wiskott-Aldrich, right, is X-linked, right? So, it has been mapped to the short arm of the X chromosome. And remember that, if you are a male, you have only one X chromosome. You have one Y chromosome. If you're a female, you have two X chromosomes. So if you're a female, you would have had to have received a defective X from both your mother and your father to get Wiskott-Aldrich. It's obviously seen more in males who only have one X chromosome. So that's the definition of a sex-linked or X-linked genetic disease. So DeGeorge syndrome, also known as thymic hypoplasia, it is a chromosome 22. Q means the long arm, and it's at the location 11.2. So it's 22q 11.2 deletion syndrome. So now you just learn how to speak gene. Okay, that's how we talk about genes. You're either going to have a 1, 2, 3, right? 4, 5, 6, 7, 8, 9, 10, 11, 12. We have 23 chromosomes, but 22 of them are autosomes. So the number can go up to 22. It has a Q or a P. The Q is the long arm. The P is petite or short arm of your chromosome. And then there's basically a gene locus or a location on that gene that is usually going to be indicated with a decimal point. And so this one is basically loss or partial loss, total loss or partial loss of the thymus. And so you'll see other congenital disorders as well for DeGeorge syndrome. But that's basically the severe kind of immunodeficiency. And then chronic mucocutaneous candidiasis. There's two types, right? Either autosomal recessive deficiency or autosomal dominant deficiency. And it's basically against the Candida albicans bacteria. Right, some B cell disorders. The most common is IgA deficiency. So basically, IgA-bearing lymphocytes fail to become plasma cells, resulting in a very low or severe lack of IgAs. Another one is Bruton's X-linked A-gamma globulinemia. A-gamma globulinemia. Sorry, that one's a tough one to pronounce. Say that one fast 3 times, right? It's basically congenital, and it's a lack of normal B cell development. So you have basically very little or no B cells, okay? You might have some transient hypogammaglobulinemia, right? A self-limiting type of condition, right? Some babies are slow to acquire normal immunoglobulin levels, so you might see that in some babies. Or common variable immunodeficiency, especially lower titers of one of our immunoglobulins, IgG, IgA, or IgM, and basically B cells are not differentiating into plasma cells properly, right? So DiGeorge syndrome is a deficiency of, right? T cells, right? T cells. All right. So secondary immunodeficiency, right? Basically you have either an excessive or defective neuroendocrine response. Those are usually that. So excessive, right? Increased corticosteroid increases susceptibility to infection, or defective is causing the opposite. Basically, low corticosteroids are causing susceptibility to autoimmunity. So some of the factors of immunodeficiency, you might see poor nutrition, stress, drugs, or surgery. So that was chapter 10. I'll come back for chapter 11.